Thank you, Madam Chair. Good morning, Excellence. It is a great honor for me to be here today, presenting on behalf of our Deputy Minister in Mozambique, who has to leave yesterday. She was here with us, and she has to leave to travel to Washington yesterday for other emergency government program. And it's a great honor for me to be representing on behalf of Mozambique. I also would like to introduce my colleagues from Mozambique. We are here as a team of 11 people, and we have a national Deputy Director of Health, Dr. Lilia, and we have diverse experts, OBGYNs, pediatricians, public health managers from the Ministry of Health, from the central level, provincial level, district level, represented in this room. And also we have our colleagues from UN agencies, WHO and UNICEF, and we have also other colleagues from USAID. So I think this representation is emblematic of country commitment and country teamwork. I would like to ask you to request just 1 second, my colleagues to stand up. Thank you very much. I am here today to present the Scaling Up Newborn Program at the national level agenda, the policy formulation and implementation in Mozambique. The presentation outline. Yes. The presentation outline will be, first of all, Mozambique at a glance, the newborn survival in Mozambique, the policy framework, the gaps and challenges in tracking newborn survival in Mozambique, and the key benchmarks for success. I would like to introduce quickly my country, Mozambique. Mozambique is a country located, I think many of you know, but for some can be important to tell that it's a country located in southern East Africa, and we have in the north our neighbors Tanzania, Zambia, Malawi, and in the south we have Zimbabwe, South Africa, and Swaziland. The country is basically a country of 24 million inhabitants, and the population is overall a young population with a population under 5 of about 4 million. As you can see, the population is basically a rural population, and is we have the population below poverty of 52%. The life expectancy in the country is 52 years, according to the preliminary data from the last DHS in 2011. Mozambique is a country with some particularities. We do have a GDP growth of almost 8%, which has been a very good economical improvement for the last year, but we still be the poorest country in the world with the per capita GDP of about $400. Some indicators here, they are social determinants, and you can see the female illiteracy is still low, and the population using improved water, which is a good, important condition to reduce newborn and to improve maternal health, is still low. This is not only for national information, but it's also for the health facilities. The government expenditure for health, although is 12%, I will show you with some trends that some areas still neglected, and the particular area that is still neglected is maternal, newborn, and child health in Mozambique. Mozambique is a country where almost 1 million of children are born every year, but almost 25 million do not achieve their first month of life. And this accounts for 30% of all under 5 mortality, and the neonatal mortality in country is about 33%. The maternal mortality is one indicator that, although we have some improvement that we're gonna see, still a big challenge. We have some anecdotal information that says that we now have information in the facilities because they are reported. We have the National Audit Committee that reported the institutional mortality. But we still have some doubts that this is really a big challenge. Mozambique have made several changes, and one important change is in under 5 mortality. From 1997, we decreased the under 5 mortality from 201 to 97 in 2011. And also we decreased the infant mortality from 135 to 64. This is a trend that shows that we are there to get the MDG5, the MDG4, but we know that the challenge is still there. If you look at the last slide the last line in my slide, you can see that the trend or the reduction of neonatal mortality is still very low, and we still have high neonatal mortality in country. Why do children die in Mozambique? The under 5 die basically from malaria, pneumonia, infections, and the diarrhea. HIV and neonatal causes. The neonatal causes basically contribute for about 30% of all under 5 mortality, with the major causes prematurity, asphyxia, which is related with intrapartum complications, and also with sepsis and pneumonia. What has been done in Mozambique to reduce the newborn mortality and maternal mortality? There are available policies. We do have in country a national newborn child health policy. We do have also integrated plan for the acceleration of MDG 4 and 5. We do have the roadmap for acceleration of maternal and newborn reduction. We have maternal and neonatal need assessment that was conducted and have been the base to design the roadmap and also the integrated plan to reduce maternal, newborn, and child health in country. We do have also the international code for marketing in breastfeeding substitutes. We do have the national elimination plan that has been approved recently based on not only prevention of mother-to-child transmission, but also for the women and the baby's health and life. Those policies are already in place, and in country we do have a platform that is the Partnership for Maternal, Newborn, and Child Health, which is led by the First Lady in Mozambique. And this partnership of maternal, newborn, and child health includes civil society, national organizations, and also does some advocacy within the government itself to ensure that the budget and the funds that are allocated in country goes also for maternal, newborn, and child health. And also, recently, Mozambique has participated in this new agenda that maternal and newborn child health is being raised, where the promise renewed, it is one agenda in Mozambique, and the strategies are being designed to ensure that we are moving towards the MDGs 4 and 5. Oh, yeah. What we have done in Mozambique in terms of clinical, in terms of interventions. At clinical level, we do have what we call model maternities, which basically reinforce the humanization of services, the evidence-based intervention, particularly the use of patograph, the use of active management of the stage of labor, the essential care for newborn, the skin-to-skin, immediate skin-to-skin for mothers and babies, and also we do reinforce breastfeeding on those model maternities. It's important to inform that these model maternities also respect the relationship between the mother and her family. Where is possible, the mother has someone, a relative, a traditional birth attendant, a mother-in-law coming with her in the facility to give her support, additional support. All those interventions in these model maternities include all the traditional interventions that we have identified under safe motherhood, the basic and comprehensive emergency obstetric care, the essential newborn care, the mother kangaroo, basically those interventions. In terms of facilities and outreach, we promote the 4 visits in country, and also, and you will see with my additional statistics that we're still very far from what we want to be. And we do know that we still have very high, very low quality of services in antenatal services, where we have been able to identify with national statistics that the blood pressure, the malaria prevention, for instance, they are still very low in country. In terms of community, Mozambique have invested strongly in community health, is investing strongly in community health workers, and is basically adopting what we call APE, a national cadre that is trained 6 months, and they are recruited from the several and diverse cadres available in countries that have been working on those vertical programs in countries. So this is one platform, and also the national strategy for community intervention is being developed and supported by community donors. This slide is just to show that our coverage, although it compares to the DHS 2003 and DHS 2011, and you can see previous speakers have shown the same figures. Mozambique is not an exception. We still also have several improvements in several areas, but the areas related, all the figures that you see related with maternal, newborn, and child health are very critical. if you, the first figure shows the CPR. The CPR in Mozambique have decreased, which is a critical situation, and it doesn't make sense if you think that we have this coverage of 9% of first visit in antenatal service, and we do have a very good coverage in BCG, the first vaccine, but the referral from the BCG service or the immunization services to the antenatal service, to the postpartum service or postnatal service, still not happening. So this is a big challenge for Mozambique, and also the malaria prevention is still very low. Those are things that concern the country. In terms of equity, we do have inequities in country, and the poorest women, the least educated women, and the youngest women, who are usually the least educated, they are the people that have less access and less quality of care. And those provinces, they are in green, they are the provinces where we have the highest inequity and the lowest data, the lowest indicators, maternal child health indicators. Yes? Yes, almost there. What Mozambique has been doing in terms of quality, what Mozambique have been doing, a national need assessment has been done to evaluate the newborn services, and we hope that the results will be the base to design an acceleration plan for newborn services, and also an implementation of existing newborn health policy is being accelerated. Although we know that is inconsistent and variable, the big challenge in the country and the big gap is, although we have the swap approach, we have the swap donor community, we still have problems with health system reinforcement. When it comes to health infrastructure, we still have problems. We still have infrastructure without water. We still have infrastructure without human resources. We still have lack of medications, of all maternal, newborn, and child health commodities. And we still have also problems with the referral system. As you know, although we have been improving slowly, now with the elimination plan, we're using PEPFAR platform to improve referral for maternal child health, and also to improve management of logistic and health system infrastructure. So that is one improvement that still needs strengthening. There are also other additional challenges, and basically the physical barriers for services, the distance, the lack of the financial barriers and opportunities costs. This is, with this, for instance, with this acceleration plan, we see that the costs of drugs, they are very high for HIV, and all the opportunities that we had before, they are getting lower. The funds that were coming from PEPFAR to maternal, newborn, child health are getting lower, although still the political will is there. We see the donors community, we see the country, the government itself is strongly committed to use all the platform available to reinforce the health system strengthening. I think I will stop here, and thank you very much for your patience and for your attention in this presentation.